participants in these meetings. But I really feel that the breakfast meetings are important because you get a focused update on particular topics that are very relevant, and I think that I'm particularly pleased the quality of the speakers this morning are excellent, and I think hopefully this will be meaningful and worthwhile. So I'm going to be your introduction to talk to you a little bit more about why we think that cerebroembolic protection is important. And I feel this with a certain level of passion, that as a physician, the extent to which we can protect the brain and protect brain injury and continue to differentiate ourselves from alternative therapies is critical. And I really believe that not just in TAVR, but in a general sense, we can develop predictable and effective therapies to provide some protection. In Israel, they have the Iron Dome. Is that right, Iron? So we need some protection for the brain. I don't have any advice that relates to this presentation that are important. I'm going to go through some key points, and a lot of this is going to be amplified by our subsequent speakers. I have lived with the specter since the very beginning of TAVR that strokes are both feared and an acknowledged peri-procedural complication. So in this presentation, which was the second New England Journal of Medicine presentation on the first randomized trial we did against surgery, we showed, I thought, some very impressive results with an early stage device with operators that were not really very well trained in terms of having experience with these therapies, and in patients who were the sickest of the sick. And the response we got in the editorial was, at what price? Really emphasizing that the stroke issue was as important as anything else. And we have lived with these data since that time, and it's been almost a decade since we began that early work, that there was about a twofold difference in strokes. At that time, we didn't even know quite how to classify strokes, but that difference was real. That is probably the only study, certainly the only randomized trial, that did show a difference. Now, it is clear, and this is an early meta-analysis of over 10,000 TAVR patients, that if you do have a stroke, it has an important impact on 30-day mortality. So it's not just the fact that we're seeing neurologic events, which in and of themselves are disquieting, but the impact on mortality is very real, and the impact on disability is even greater. Over time, I think the stroke frequency after TAVR has declined somewhat. There's no question about that. And I believe strongly that in more recent studies that it is clearly non-inferior and may even be less than what we see with surgery. So these are data from the Partner 2A randomized trial looking at surgery versus TAVR. These are intermediate risk patients with STS scores between 4 and 8 in general, a median of about 6, and you can see the stroke rates track almost identically. And if anything, numerically, surgery was slightly higher. So no difference in randomized trials. So this is not a unique problem just to TAVR. And the more recent CERTAVI study, also in intermediate risk patients, you see, in fact, if you look at disabling stroke, you actually see a difference. And that difference favored TAVR versus surgery, which again is an interesting observation. So no real difference between TAVR and surgery. But I would still argue that whatever the stroke risk, it is significant. And in the modern era, the way we define strokes, it is more significant than we had previously appreciated, and it's not importantly affected by operator experience. This is an interesting slide looking at contemporary TAVR devices. And this is looking at all strokes. And I think you can see it varies quite a lot from study to study. It's ascertainment, definition dependent. But you see stroke rates as high as 9%, 7%, 5.5%. So this is not a trivial number in our minds when we're talking about a procedure that is being performed now in large numbers of patients. In the most recent randomized trial, the REPRISE 3 study that was presented yesterday at a symposium and in the main arena, the stroke rates, as you can see, were no different between the two devices, CoreValve and Lotus, 4.3 and 4.8%. These are 30-day stroke rates. But it's 4.3 and 4.8%, which is, to me, a significant number. And if you look at the STS database, and this has been pointed out again, this was presented in the main arena yesterday, the first cut at that database at almost 50,000 patients, whereas there was a volume outcome relationship for mortality, for vascular complications, for bleeding, it was not present for strokes, which is to say that I don't care how experienced you are. These are random, unpredictable events that experience does not protect you from having strokes. So even the most experienced operators are going to be faced with the reality that they are going to have a level of strokes that it is going to be unpredictable, and to those patients, it is absolutely devastating. Most of these strokes occur in the first 72 hours. Now, we saw that in the first part of the trial. 73% of the strokes that occurred within 30 days occurred in the first 72 hours. These are two other studies. This is the Canadian study from Laval, and this is France 2 from Didier Cheche. Clearly, the majority of these events occur early in the first few days. We can argue about exact timing. This is a very nice analysis that Samir Kapadia did in the expanded partner group of over 2,600 patients. And we did this very complicated statistical analysis with Gene Blackstone that only he could understand. Looking at stroke frequency, what you see there is this acute phase effect. And this acute phase effect demonstrated that the vast majority of the measurable strokes occur in the first 72 hours. Stroke frequency is highly definition dependent. So the classification, ascertainment, whether or not you do neurology assessments and what they are, and thresholds for detecting subclinical events, I think vary dramatically from study to study. And I have to really credit Alexandra and her group. NeuroArt did a spectacular job of putting this into context and really memorializing this. A lot of the early data on this, and I also credit Steve Messi because he did a very interesting study called the De Novo study looking at surgery, and finally put to rest the notion that the surgical patients are protected from strokes. And if you actually look at these patients carefully and look at some of the subclinical or less obvious clinical effects of strokes by having neurologic ascertainment, the stroke rates are much higher than we had previously appreciated. And I think all of this led to some really provocative analyses. This is one of my now new favorite slides. This is a patient-level pooled analysis from the multiple TriGuard studies. This is 142 patients. Looking at the frequency of neurologic events, depending upon what variable you look at. Whether it's a disabling stroke by VAR2 criteria, all strokes, HA stroke definitions, looking at cognitive function, looking at NIH stroke scores, or looking at DWMRI. I think you can see that depending upon what variable you look at, you can have stroke rates as low as 1% and as high as greater than 90%. But if we're talking about brain infarction, loss of neuronal tissue, neuron cell death, this occurs in the vast majority of patients who have TAVR, almost 100% of patients. So Alexander's going to talk about this, so I'm not really going to mention it other than to acknowledge this is a beautiful publication, and this was a great analysis to be able to typecast strokes and to be able to talk about the classification, how you apply endpoints, how you assess these neurologic events. You'll hear much more about that. I like this slide from Eberhard Grube because it really does characterize in visual terms what we're dealing with. We're dealing with obvious major disabling strokes, of course, that's the devastating tip of the iceberg. But we just don't have a good idea as to what the importance is of these silent cerebral infarcts that occur in the vast majority of patients that have cardiovascular procedures like TAVR. And that really is the dilemma. You know, how we characterize the importance of cerebral injury and what are we going to do as therapeutic proceduralists to try to minimize the impact of those things. To just refresh you again, 10 studies with DWMRI showing that you can measure very clearly brain cell death in 65 to 100% of patients after TAVR. This is not an infrequent event. This occurs generally. Now, what the clinical impact of this is what people keep discussing. That's one of the controversies. And at what level do you apply a new therapy to minimize those effects? I like this slide because it points out some very significant things. We used as one of the endpoints in the Sentinel trial, one of the major effectiveness endpoints, a surrogate looking at diffusion-weighted MRI imaging. I think we've learned since then it may not be the best surrogate endpoint to use. I mean, we can measure a lot of things, but I'm not sure that it was the best surrogate endpoint. In any event, these are control patients who are not protected. They all had strokes. And by the way, the level, the NIH stroke score on each of these 3 patients was identical in terms of the magnitude of the stroke. Look at the differences in DWMRI imaging. in terms of lesion size, number, and location. You can have a small lesion in the wrong location and have the same effect as a huge cluster of embolic shower that really affects 20% of the brain. So these are the things we learned in doing some of these studies, which, by the way, makes doing some of these studies frustrating. Patient perceptions regarding the importance of strokes may vary, and they have exaggerated impact beyond the actual event frequencies. I really like some of the work that Megan Coyle-Wright is doing. She's a great interventionalist from Dartmouth, where she talks about patient-defined goals, and she did this interesting questionnaire and study of patients after TAVR to ask them what's important to them with respect to aortic stenosis therapy with TAVR. Only 7% of the patients said that mortality was important. That's not what they cared about. Reducing symptoms, 15%. Maintaining independence, 30%. But almost half said the most important thing was the ability to do a specific activity. So you could still be alive, but if you can't run, if you can't play the piano, if you can't dance with your wife, or your spouse, excuse me, those are important things to people, and we have to stop just talking about mortality and start thinking about things that are important to patients. And in the elderly, a stroke is worse than death. Maintaining independence is critical. Quality is more important than longevity. In younger patients, of course, we care about mortality, but we're concerned about cognition, mental acuity, and rapid return to quality of life. CEP filters do show impressive embolic debris liberation, and we've seen that in multiple studies as shown here by Von Meegen and what we showed in the Sentinel trial, measurable debris in the majority of patients. The totality of evidence, which you're going to hear about, shows improvement in clinical and neuroimaging findings. These are the 3 devices that have been used clinically in patients. I'll just point to this one study, which will be mentioned later, which is a meta-analysis showing a greater than 40% reduction in hard endpoints of stroke and death if you look at this meta-analysis of all the data available. And then finally, I think the use of CEP, whether you believe it should be selective or systematic, is really a shared decision-making process where there's a discussion with the patient and with referring physicians and with others about what the risks and benefits are. So I believe that the need for cerebral embolic protection is there. Whether we have the perfect devices at this stage, whether we can demonstrate it with conclusive, definitive evidence and complex randomized trials, I think we can debate some of those specifics, but I think that the need is there, and I think we really need to be focused on our ability to be able to address that need with accessory therapies that are going to protect our patients from brain injury. Thank you.